are the underlying mechanisms of glomerulonephritis and sclerosis in patient populations with kidney disease? And what about clinical presentation, diagnosis, and risk stratification? Can clinical trial data provide insights on the challenges with current standards of care? This is CME on ReachMD, and I'm Dr. Jürgen Flöge.
And I'm Dr. Jonathan Barrett.
And I'm Dr. David Jane.
In this first chapter, we'll look at immunoglobulin A nephropathy, also known as IgA nephropathy or IgAN, with a very interesting patient case of mine. So here is Mrs. XY. She first presented to me about 2 years ago with a GFR around 50 to 60. We did a kidney biopsy, found IgA nephropathy. Remarkably little activity here, so M0 and E0 imply there was very little proliferative change. S1, so this was some glomerulosclerosis, and almost nothing in the tubular interstitium and no crescents. And what you see down there is the course that she took at the time of the kidney biopsy. Her GFR was 47. And then right under my eyes, she dropped to 35 within half a year. In terms of supportive care, she has well-controlled blood pressure. She follows a pretty reasonable diet. She has a diuretic. She's not obese and she doesn't smoke. So in terms of optimizing her supportive therapy, there's pretty little room for improvement. The guidelines say we recommend that all patients with a proteinuria above 0.5 gram per day, irrespective of hypertension, receive a RAS blocker, a 1B recommendation, and clearly we've done that. Here comes the tricky part. We suggest that patients who remain at high risk, and she clearly does with her proteinuria of 1 to 2 grams, are considered a 6-month course of steroids. But you need to discuss the important risk of treatment-emergent toxicity with a GFR below 50. And you shouldn't even consider this at a GFR below 30 in a diabetic, obese, etc. Why am I so skeptic about steroids? Well, this is the German study that we did some time ago. This is the long-term outcome of the patients, and you can see that adding immunosuppression to a comprehensive supportive regimen did not increase the chances to stay free of death, dialysis, or 40% GFR loss. It just added adverse events. This data has been challenged recently by the testing trial. Testing used the same primary endpoint, 40% GFR loss, dialysis, or renal death, and we clearly retarded the primary endpoint. However, this came at the price of 6-fold increase in serious adverse events. So we were forced to halve the dose of the methylprednisolone. We still had 2.5 times as many SAEs, but this too worked and it retarded the onset of the primary endpoint. But there are two notable things here. First of all, this is an almost purely Southeast Asian population. We know IgA nephropathy is more severe in Southeast Asians. And the other notable thing here is that the event rate starts to become parallel after about 2.5 years. So we were very thrilled when this study came out. This is the phase 2 study of target release budesonide, an encapsulated budesonide, where much to our surprise, the 9-month treatment period resulted in a totally stable GFR, whereas GFR dropped significantly in the placebo group. At the same time, SGLT2 inhibitors made it into glomerular disease, non-diabetic glomerular disease. And this recent meta-analysis concludes that in IgA nephropathy, being on an SGLT2 inhibitor reduces your likelihood of the primary renal endpoint by 50%. So what did I do to my patient? I did both. And look at what happened. She went into complete remission proteinuria-wise, and quite remarkably, her GFR stabilized out at a very low level. And you can see that she has maintained a stable GFR for half a year, which she never had before I saw her. but then she developed a deep vein thrombosis and pulmonary embolism. And I've now started to taper off her budesonide.
So, Jürgen, in terms of therapies that are currently being evaluated or perhaps are potentially going to be approved in the next 2 or 3 years, if they had been available, what kind of approach might you have wanted to take?
Very clearly, if I were to see this patient today, I would put her on combination therapy right away.
And with the only other drug really that's close to approval is sparsentan, which is an endothelin receptor antagonist. Do you think an endothelin receptor antagonist would add value in this lady's case, bearing in mind the data showing that they have a significant antiproteinuric effect as well?
Yes, I would clearly consider sparsentan or any other endothelin receptor antagonist because one, they seem to be very safe, and B, there's reasonable evidence already now from phase 2 studies that if you add them on top of full dose RAS blockade, they have an additive antiproteinuric effect. So clearly this lady calls for combination therapy.
I note that the ACR reduced down, but it was still quite abnormal. And I just would be interested in your comment on what a target should be.
Good question. Her lowest proteinuria was 0.25 grams per gram. In a woman almost close to normal. And I think if it were me, given that proteinuria is such a strong predictor of progression, I think ultimately this is what we should aim for, to have proteinuria go down to the normal range and not just below 1 gram per day. Now, in chapter 2, we'll have a look at a case of FSGS. Stay tuned.